Well, thanks very much, Ian, and thanks for having me. We know that recurrent instability is an issue with the young population and that bone loss significantly amplifies those risks. And I think we should really think about critical bone loss both from a glenoid and a humeral-sided aspect. And what we consider to be too much glenoid bone loss is really evolving over time in terms of what we can do arthroscopically, as we'll discuss. And then our understanding of bipolar bone loss and glenoid tract concept also continues to evolve. I think there's no question that if you're over 20% bone loss, you need a bone reconstruction. That value maybe is anywhere between 13.5 to 17.3%, depending on really what literature you read. And then maybe even more recently, that is an even more subcritical threshold at 10% if you factor in demographics and risk factors. We know that we should really consider bipolar bone loss, including the glenoid tract, and I think most of us understand how to make those calculations. There's less written about how to measure the glenoid tract. This is a recent study that we just did looking at CT versus MRI, and I think because of the number of slices that are required that you get from a CT, the reliability actually of a CT is actually less than with an MRI. That's not to say that a CT scan is less accurate, but at this current time we have felt that the MRI is a little bit more reliable to make those measurements. So then you make your measurements. In 2014 we understood this treatment algorithm where we could say, okay, are you on or off track, and it then puts you down an arthroscopic or an open procedure standpoint. There's no question if you do a remplissage for an off-track lesion, this diminishes your risk of recurrence significantly. But I think it's more useful to think of the glenoid tract as a continuum rather than a binary on versus off-track concept. A few years ago, we coined this term distance to dislocation, which is simply a subtraction of the Hill-Sachs interval from the glenoid tract. And what that gives you is it gives you how far an on-track lesion is from becoming off-track. In preliminary studies, it turns out there is a distance. If that distance is less than 8 millimeters, your risk of failure increases significantly. And these worrisome on-track lesions we were termed near-track lesions. That threshold also decreased the younger you were, which is anticipated. And then in further studies, we found that as that distance decreased significantly, so if the closer your on-track lesion was to becoming off-track, the more likely you were going to fail an arthroscopic Bankart, and that inflection point appeared to be around 10. Another finding that we found was that the collision athletes don't even seem to abide by this track concept. Their risk of failure is so much higher that it doesn't even matter if they're way on track with their Hill-Sachs. And so it does matter how far an on-track lesion is from becoming off-track. Not all on-track lesions are created equal, and that collision athletes in particular don't even seem to follow this, this concept. And so for these at-risk patients, near-track lesions, contact athletes with on-track lesions, perhaps something more needs to be considered. There are also bad combinations as well. If you have a near-track lesion with somebody with hyperlaxity, your risk of failure is pretty significant, regardless of even how much glenoid bone loss you have. And as we learn more about the humeral side of this equation, inferior extensions of on-track Hill-Sachs lesions are also highly predictive of failure with an arthroscopic Bankart. And so this is a visual depiction of what an expanded glenoid tract concept would look like. DTT less than 0 by definition is off-track, greater than 0 on track, and then there's this worrisome on-track lesion we term near track between 0 to 10 millimeters of DTD. Now, if you add a remplissage to an on-track shoulder, you can diminish the risk of recurrence significantly. Pat Denard and I wrote this paper demonstrating that if you do this in high-risk individuals, you can diminish the risk of recurrence pretty significantly in on-track shoulders if you add in remplissage. So the question is, if you have add a remplissage and it diminishes your recurrence rate, who should you be performing this on? So we've done some studies looking at prognostic factors, as well as trying to establish a risk assessment score, which we term the Pittsburgh Instability Tool, or the PIT score, to determine whether or not a remplissage would be useful. And so from these studies, we determined that the factors that would affect outcome include age, contact sports, hyperlaxity, near-track status, the number of preoperative episodes, and the percent of glenoid bone loss. And this is a little bit of a busy slide, but what it shows is as your risk factor burden increases, the protective effect of a remplissage increases as well. So maybe in other words, as risk factor burden increases, the less number of patients you need to treat for a remplissage to reduce your risk of recurrence. You can then take weighted hazard ratios and make a score, and then that we term the PIT score that can classify these patients into low, moderate, high, or extreme risks. And when you add up these scores, a remplissage can then diminish your score by 10. So in pictorial form, this is what it looks like. So for example, if you're a low-risk patient, you may not benefit at all from having a remplissage. If you're a high-risk patient and your PIT score is 12, you diminish that score by 10 if you do a remplissage, which then puts you in a low-risk category. That is a patient who might benefit from remplissage. And then lastly, let's say your score is 26. You do a remplissage that puts your score to 16. You're still at an extreme high-risk category. That patient may not benefit from an arthroscopic approach at all. So this is a bipolar bone loss 2024 revisited. I think this value is 10 to 20% in terms of the critical bone loss. Near-track lesions deserve a little bit greater attention. And then the question now is remplissage for on-track shoulders. This may be very dependent on the risk factor burden of the patient. Thanks very much.